Oh, yes. Yes, yes. Sepsis can.
Yeah.
You're right, yeah.
Any infection can cause SIADH related
And sepsis,
hyponatremia
yeah.
or dehydration related hyponatremia. Both can happen in infection. Okay, one important concept that she said, and something that involves family physicians, is the concept of hospital at home. Hospital at home is something that we must get more and more familiar with. We already know, you already have patients who are being treated, they have a Fowler bed, they have an oxygen concentrator, they have a suction machine maybe, etc. at home. And this has to increase. And hospital at home, as she said, involves a multidisciplinary approach. So just by you going as a family physician and doing things, maybe you will have to create a team. What kind of team should they create?
So hospital at home is now, we've always had it here in some form, but in the West it is now a new concept, partly because of their remuneration. How do you get insurance? How does you allow insurance to pay for hospital at home? They say they're not in hospital. Anyway, that part aside, the true definition of hospital at home, and I say true because we're all dictated by what comes out of America, their definition is that it will be, the patient will have a doctor's services at least once a day, in person, once a day in person, with technology multiple times a day through online. Nurse also, at least once, like a hospital visit. So are you going to wait for the hospital team to come? No. It's more, those who are doing it have a community-based team where 10 people are in the roster, you have to travel to each house and look at them. But throughout the day, online should be, at least a nurse should be available. And if any diagnosis has to be done, should be available at the home or may have to go, say for ultrasound or something. So the idea is you're trying to replicate hospital services, but in the patient's home, so that you don't have all the downside of hospitalization that we talked about. But having said that, we know that it's impossible for all people. Now, chronic illnesses, as you said, many people are having, like COPD, oxygen, home oxygen, that's not hospital at home. Fowler bed, that's not hospital at home. That's just long-term care at home. So some patients absolutely cannot have hospital at home. That is, if on oxygen, they're still desaturating. If they're on oxygen saturating, they could still be at home. Any hemodynamic instability, obviously, cannot be at home. But, and of course, if there's an acute stroke, acute coronary syndrome, because acute coronary syndrome is one thing which is very good outcome of treatment even in an older person. So such patients who are rapidly evolving and you think it's acute coronary, certainly no hospital treatment, no at-home treatment. But, so what are the kinds of things? It's not just the ability to go and give injections in the house. That's not hospital at home. That's just home care. But somebody who needs that doctor and nurse to visit, that, so things like septicemia, if they are hemodynamically stable, they could have, you could have that early stage of sepsis. You can give IV fluids, you can monitor it, you can give the IV medication, teams come in and do all that. Something like deep vein thrombosis, very common in the elderly, and now, even heparin, subcutaneous heparin can manage. I have managed several patients in the house with deep vein thrombosis and they haven't gone into, but if they do throw an embolus in spite of that, that's unlikely once you've started the treatment. Then of course they have PE, has to be hospitalized. So basically it's infections, deep vein thrombosis, and then acute exacerbation of COPD also can be, because you can do a non-invasive ventilation in the house. But if they need invasive ventilation, you have to admit them. So these are the kind of things people have been looking at as true hospital at home, and thereby try to make sure that the beds are not clogged up with all these old people who take longer time to recover, and then they get bad in the bargain themselves.
You know of these organizations?
Hello. Welcome.
No, no problem, no problem. You can please, you can please carry on, no problem. Welcome. Hospital at home, many of you have heard of organizations. Hospitals also, in fact, Nanavati Hospital will do a hospital at home management, etc. Most of these organizations that do hospital home do not involve a family physician. Am I wrong, or is that right? Yeah, now what I would request, if you have patients who require hospital at home and you want to take services from an organization that provides everything, nurse coming in, every day RMO coming in, you should be actively involved in taking care, because the patient requires you more than they require an unknown or stranger doctor. And you must take care. And I think it's something that we can train ourselves to do fairly easily because of your experience. You can do this fairly, but get involved. And what will happen, as she said, is if we start sending every elderly patient to hospital for pneumonia or pyelonephritis, which is not very severe with no hemodynamic instability, we are causing more damage than we are taking care of. So we must learn to say no, don't get hospitalized, even though you have a pyelonephritis, because it is mild and we can manage at home. And then you get involved with somebody who will do parenteral therapy, etc. at home.
I fully agree with you, but it is a responsibility to have the team.
Yeah, the team is necessary.
Make sure that there's no weak link over there.
Yeah, the team is necessary. So you find out the team that in your area provides services like this, and then get involved on a daily basis. You will also have to visit every day.
No, and I'm thinking that as a future thing, though we usually they talk about hospitalists, but there are one or two doctors who have written personal accounts. They got fed up with hospital medicine, so they decided they're just going to do home visiting. Say, there's a gastroenterologist in the US. He says it's so much nicer to go and visit all these old people. He learned some geriatrics, and he was seeing them in their houses, both as just visits because they were too old to come to the daycare center, and because they needed services of a doctor. So why can't a family doctor be trained, who's got a little bit more idea about geriatrics, be the doctor who goes to visit? Why a hospital doctor? You can be the doctor.
So I would like you to think about this as how you can do home care for even patients who may require hospitalization, and come up with a structure. And if you can come up with a structure, let us together build something that might become hospital at home as in structured organization. Okay, we'll move from iatrogenesis.
Drug of choice for UTI.
In the elderly.
It's no different from younger. Whatever you're doing in younger. Nowadays, people are giving phosphomycin as the first drug, single dose. It's 3 grams, I think, 300 rupees. But what do you think about it?
She's very cost sensitive, yeah. So she'll mention that every time, yeah. But yeah, so phosphomycin, of course, is for a lower UTI, typically approved in the US only for females with uncomplicated cystitis, not approved for males at all, in fact. And you can, no male, it's not approved for males.
I didn't know that.
So yeah, Dr. Lopa, I'll repeat the question. Okay, she's asking if an antibiotic associated diarrhea happens to the elderly at home, what should be the metronidazole dose and for how many days?
The same. 400 milligrams TDS. Yeah, they tolerate metronidazole.
Maybe 5 to 7 days?
Yeah,
5 days,
5.
Yeah. Any more? Yeah.
But please prime them with probiotics. At least I believe in probiotics for this one condition.
I'll just repeat the question. She's saying that metronidazole has drug interactions with cardiac drugs. And is that a problem? And I think warfarin is what she might be referring.
Warfarin, alcohol. They're taking alcohol.
Yeah.
They can get.
Alcohol is a good cardiac drug. At least I think so.
But which drug are you thinking of? Which drug are you thinking of?
Basically, she might be thinking of amiodarone. And warfarin,
amiodarone.
as they have drug interactions.
Warfarin, okay. Yes, yes. But warfarin, how much is the use of warfarin now? Of course, if your patient can't afford and needs
NOACs.
anticoagulant, you have to give warfarin, because the newer drugs are 5,000 rupees a month or something like that. But yes, I think they are quite all right with, but not everybody is on warfarin.
We're going to, sorry. I'll answer that. Metrazole drug interaction with beta blockers probably not there. With you said with antiplatelets, probably not there, but we will revise. I mean, might be forgetting, but I don't think there is.
I'm not aware of antiplatelet.
We'll go to the third eye. We are at 10:30. We are working on time. I will request Kumar to just check if tea will be served at 11 with the canteen whenever you can. The third is instability. How do you define instability? Which diseases cause instability?
Instability is just a big word. What we're meaning is falls.
Falls, yeah.
Falls, okay. So elderly people, falls is the other big thing that they sort of fall into the grave, you know. One fall is a step into the grave. So we have to identify the risk of fall. Don't wait for the person to fall. Who is the one at risk for fall? And tackle them and make sure that all the things which are likely to give falls should be taken out. And assess every old patient, even if he looks like a fit Amir Khan or whatever, just suspect his musculoskeletal stability. And that is where at some point we have to talk about the comprehensive geriatric assessment, which general practitioner is well placed to do. So you have to test their stability. How to test it? That means there are many tests, okay? I'll just tell you one that I do, and that is get up and go test. The get up and go test is you make the chap sit down here 10 feet. You put a barrier. Ask your nurse or somebody to make him walk from there to there, turn around and come back, and time him. There's a timed get up and go test. And sit down again. So if it's anything more than 10 seconds to do that, okay, some of them will try to run and do all kinds of things. Just tell them at your normal pace, do it. And if it's more than that, you have identified that this person is slow. There may be so many causes for it, but he's slow. This is like a screening test, okay. And there are other tests also. I don't know whether I should go into all of that, you know, it's the chair rise test. You can just look it up, chair rise test. So these are all screening tests which, or anybody in the history who has fallen in the last 6 months more than once. So these are actually questions which have to be put to everybody. You can't do it in a 5-minute, 10-minute consultation. So there has to be a separate mechanism by which every patient has to have a database surveillance thing with, this is known as comprehensive geriatric assessment. So you ask these questions, screening tests. If he's fallen twice, or this is his second fall in 6 months, immediately he has to have the full assessment. So there is a battery of tests to be done. So any older person with no comorbidities can have a risk for fall, okay, because of poor musculoskeletal deconditionings. It may be the extreme of sarcopenia and frailty, or it may be just another person who's never exercised, just sits and watch TV, okay, maybe 75 years old, maybe very unstable. Then of course there are all the diseases, say neuropathy. So many diabetics are there. They may not complain of paresthesia, but they may have. Very often they have the subjective symptom of neuropathy. Objectively you can't. Whatever it is, if they have got neuropathy, subjective or objective, they are likely to fall. They are high faller risk. So then of course, people can fall because of syncope. So syncope is another very big thing in an elderly person. How do you make the moment a person falls and they come, you have to identify conscious collapse, unconscious collapse. So the conscious collapse is a person who knows that he fell. He can tell you, I went to the bathroom, I fell, and after some time I somebody help me up. And unconscious collapse is somebody who's got cardio-neuro problem. So usually it's cardio. He's got either complete heart block, or he's got arrhythmias, he's got aortic stenosis. Somehow the cerebral perfusion was low and he had a syncope. He will not know how he fell. So he said, I just found myself on the floor. There you must examine because that person doesn't come into our false category for the geriatrician. That person is persona non grata. He must go to somebody else. Please get out of my clinic. Go to the specialist who can prevent your syncopal attacks because you are at grave danger of dying. So aortic stenosis, auscultation will reveal most of them, but we all know that innocent systolic murmur due to sclerosis of the aortic valve is very common. Every second patient, if you care to listen, has got a systolic murmur. But it's not aortic stenosis. So how do you make out? Nowadays, I don't know how many people are good at auscultation. In hospital practice, because we have to teach our juniors, we are very good at it. So the second sound will be loud in sclerosis. It will be soft in a stenosis. The murmur will not be conducted to the carotid in a sclerosis. It will be conducted and of course if it's very severe, then of course you will have this pulse, low volume pulse, most of the time you don't. So if you've detected that, immediate echocardiogram and send to this thing. Then there could be arrhythmias. Resting ECG may not show. You may have to have a Holter. So such patients with unconscious collapse, you must try to identify and send them off for other tests. Otherwise, conscious collapse, we have to look for postural hypotension. That is one very important thing, because they may not they may also come like a syncope. So every person who's fallen, sometimes what happens is, I had a person recently, one of my friends, who injured his shoulder when he fell, normal walk. And he went to the orthopedics and everybody got caught up with the fact that they wanted to immediately operate and stitch up his rotator cuff and all those kind of things. I wasn't interested in that. I was more interested in, Murli, how did you fall? He said, he's a hatta-katta cardiothoracic surgeon, how did you fall? He said, I was getting woozy. I knew I have to go and sit down. There was a bench there. I charged for it too fast and toppled over on my shoulder. So I said, what's your standing blood pressure? I don't know. So I checked, he's 80 years old. His sitting blood pressure is 110. I said, what business you have to have a sitting blood pressure of 110? And he said, but my standing also is 100. It's above 90. I said, no, for a 90-year-old with sclerosed vessels, it's too low. So I had to fight with him. He thought, I'm only a geriatrician. My cardiologist told me to take these drugs. I had to ring up the cardiologist, plead with the cardiologist and say, can we take off this drug for him? Oh yes, doctor, please do. So what I'm saying is, and he's never fallen after that. He's had full assessment by a physiotherapist. He has no muscle problem. He has some peripheral neuropathy and things are fine with him. Now he's battling this. So you see, postural hypotension again is a very common thing in the elderly. One, aging itself causes postural hypotension. Then some of the drugs will cause postural hypotension. So especially combination of drugs. Your patient is having, we try not to give alpha blockers. We give it only as a last resort. But the alpha blocker creeps in when he goes to the urologist, okay, for nocturia or for prostatic outflow. So he gets a tamsulosin or he gets a silodosin or something. And then people forget that now the urologists are very clever. Since many of the urologists, they also are on these alpha blockers and they say, oh my God, I didn't know it felt so woozy and all that. Now they're very careful with their patients and they also ask for dose reduction of the antihypertensive medication. But it's such a common thing that it should be at your fingertips to check postural hypertension. At least the first time that you see the patient, then any time he's feeling dizzy, giddy, going to fall, postural hypertension has to be checked. So these are some of the common causes, but try to identify. The majority of the falls actually are the conscious falls, slip. So it's the house, no wires like this, no mats unless they are, what do you call them? Skid resistant, and handrails everywhere. No wet feet. I tell all my patients, please have a bath sitting down, or soap your feet, wash them, then have the rest of your bath, because some people insist on having oil bath, in the south. Oil and soap is a horrible combination for falls.
About postural hypotension, just a second, I'll just finish this and then we'll take this. About postural hypotension, let me digress a bit. Hypertension in the elderly is often treated with medications, and we do advise that we should check standing blood pressure every hypertensive on antihypertensives. What is your view on a person who has 170 by 80 supine and 130 by 80, 70 standing? Do you increase the dose because the systolic is 170 in the supine? This query comes because it is a common thing, and I don't know whether I should treat the BP in standing or should I treat the supine BP to adjust my dose?
Always the standing BP, always the lower BP, because most of the time you're standing. Number two, if you try to bring the standing down, you're going to get a fall. So you have to play between the two, and it's a lesser evil. Standing blood pressure should not go below, definitely below 110. The other thing is to get the diastolic down. So somebody's got usually the elderly have isolated systolic hypertension. And so while we're trying to bring the systole down, diastole also will go down. So you cannot afford to let the diastolic go below 60. My diastolic blood pressure is 55, okay? But I worry about that. Yeah, I worry about that. My systolic needs a little reduction. Let it be, because it's been proved. You bring the diastolic down, it does not harm you immediately. You don't know the difference. But your tissue perfusion is suffering. So if the tissue perfusion suffers, you're going to deteriorate in your general health without your knowledge. And they've shown higher mortality with a low diastolic. I'm not talking about patients with aortic incompetence. That is different. It is people who don't have aortic incompetence.
So for us, diastolic blood pressure should be not below 60, and digital BP instruments will often give a low diastolic, lower than the mercury instruments. So rely on...
I didn't know that. Is that so? Okay.
So we should rely on mercury or even aneroid BP instruments, and not on digital in the elderly especially. Yeah, we can take a couple of questions. Yeah, so she's asking if home equipment to prevent falls.
No. The tests.
So she's asking about geriatric comprehensive assessment.
Yes. So it's all available, and the thing is, it's all there. Now there's one thing known as Edmonton Frail Scale, which I've got it on the thing. I can give it to you. It's like compressed, so like a screening test, which tests all the domains that go wrong. It tests cognition. It's just a screening test. Huh? It tests cognition. It tests functional capacity. Can you go to the market? Can you get onto this thing? Can you remember your drugs? And so this thing has been found as a very good scale, and it gives you a numerical figure which says frail, non-frail, vulnerable, not vulnerable, things like that. Yes. So this is a very short scale, which even you might find it difficult to do in a consultation. You will have to get an assistant to do it, because it will take up all your time. It takes at least 10 minutes to administer. So train somebody to do it for every patient before they come into you, if possible. Or not that visit, another visit. The detailed geriatric comprehensive test actually does much more detailed. I think I can send it to you. So they are checking vision, hearing, just by questions, and by doing simple tests. Like hearing is tested by going behind the patient and whispering something to him and asking him to repeat it. You stand in front, they will read your lips. So like that. Then get up and go test is just one of them. So comprehensive geriatric assessment can be done in full if you're got the time and you have somebody to do it for you. This Edmonton Frail Scale kind of makes it a little bit more compact. The other thing nowadays, is this the time to talk about it? Yeah. ICOPE, integrated care of the older people. ICOPE. As I told you, WHO has identified this as the decade of healthy aging. So what they have proposed is for community. Now these are, we talked about when they come into your clinic. In the community, they propose that health workers who are not even doctors, nurses, anybody, even a social worker, can be trained to go out into the community and check 6 domains which are very important for something they call the IC, intrinsic capacity of the person. 6 domains, of which vision, hearing, cognition, psychology, nutrition, they call it vitality, and there has to be one more. These things are tested by screening tests. And the screening tests are like extremely mobility. So these are very, very simple tests. And if they pass that test, for example, the chair rise is one. How many times can you get up in 1 minute with hands like this? All these. If you pass the test, you're passed. If you don't pass, there are steps in that. If you don't pass the test, what happens? Then a few only get referred to the hospital. So these are being referred to the hospital even before they know there's anything wrong with them. So nutrition, very important for a concept of frailty, as we now think very big. Everybody's talking about frailty in the elderly. Nutrition, you may be well nourished, you answer these tests, you go. You don't answer these tests, your BMI is like this, you are at risk, like that. So for everything, for eye, for hearing, everything, mental, cognition, these are all the important things which make a person's ability to live independently in the community. That's what we call intrinsic capacity. So some things have been excluded, you know. So for example, heart, nobody's checking the heart, nobody's checking the BP in this ICOPE. Why? Because if you have decompensated cardiovascular status, you won't be able to do that exercise test. It may not be only a muscular thing. It may be something else preventing you from doing it. So everything can be picked up by these. This is all well validated, lot of studies and all that.
So what we will do is get the assessment, comprehensive geriatric assessment tests or scales from her, and we will pass on them on the group that we have created. Some of them may be not very difficult to implement, but can be time consuming. Since we were talking about falls, tell us something about the importance of recognizing and measuring sarcopenia. Can sarcopenia be measured?
Okay. So sarcopenia is wasting of muscle, literally. And it's part of another whole disease which I just mentioned as frailty. So frailty is something where a person, literally I think of it as a person who shrinks. So we come across some elderly people who are just like this, you know, bent, slow, cognition may or may not be poor. So 5 things are there. Anorexia, which may be due to other things also, but what we're saying is excluding everything. They're anorexic. They have unintentional weight loss. Maybe due to the anorexia, maybe without. They have slow walking speed, okay? And they have low energy. And if you check their grip strength, there's a particular gadget which we all don't have, grip strength, that's also low. So out of the 5, if they have 3 things, we can say them as frail. Or the Edmonton Frail Scale that I talked about can also give you a number which says frailty. So sarcopenia is the most important part of that, all those symptoms, the grip strength, the slow walking speed and everything, sarcopenia in frailty in the adult. And we are not talking about muscle atrophy in a person who's had a stroke and all those things. Those are well defined. So why does this happen? What is the biological basis of sarcopenia, and I extend it to frailty, is a subject of intense research. And they've coined a word called inflammaging. Inflammation, low-grade inflammation in old age. So some people would like to believe that we age because of a kind of molecular disharmony that is taking place, which is causing inflammation by, what means not by bacteria per se, but by reactive oxygen species, you know, these ROS and some low-grade viral infection, some toxins, some radiation, toxins in the air which we don't know exist. So all these things together act on the mitochondria. There are certain types of molecular things like epigenes and all that, and they cause inflammation. And this inflammation kind of eats up your muscle mass, eats up your vitality. It's like having a slow tumor inside you, low grade. And they say that inflammation is the cause of frailty. So people are trying to see now how can we tweak that? But that's quite elusive at the moment. So if you identify a frail person, what you have to do is things which are partly successful, because we don't know how to retard the process. There is no magic pill. Ashwagandha and ginseng and all those things just don't work. But so at the moment, no answer from allopathy, but they do say exercise and, you know, resistive exercises as far as possible to improve that muscle hypertrophy. So in the West, the old people, the 75-year-olds, are all going to gyms and doing all kinds of things. So I don't know. So you have to be very careful about this, because if he's got hypertension, please don't make him do resistive exercise. He's going to get a stroke. So at least physical fitness with the help of with a physiotherapist or whatever. Then nutrition. Lots is going into nutrition. And here we come across this thing about what is nutrition. Nutrition is protein. It is antioxidants. It is micronutrients. Less carbohydrates, less fats, protein. In a vegetarian country, in a vegetarian state, how do you give protein? To the extent, now the whole world is going through vegetarianism, which is, I think, a good thing. But actually, there's nothing like meat, as far as I'm concerned. But in the vegetarian domain, there is a whole lot of things one can do to give all the amino acids that are required. And so protein content has to be increased. And I am a strong proponent of soya, though I hate it. And I think that if there are people here who know how to make soya palatable, tasty, please tie up with industry and bring us something, because whatever soya is there now is just horrible. But soya has got such a high protein content, but of course there's a little bit of fat, not that much as. And then again our peanuts. You know, we are a country where peanuts are growing all over the place. Peanuts, though the fat content is high, it's a good source of protein, you know. So as a snack we all eat, but the snacks are full of salt and what all. So what you do is you take raw peanuts and nicely get somebody else to roast it for you. And keep popping it in your mouth and feel no guilt at all. Because you've got your protein, you don't have the salt, and your craving for food is satisfied. So I think we as Indians are well placed to show the world how to increase the protein content of diet, especially for the elderly, and make them strong. And then, I don't know how many people are here for whey protein. How many people like whey protein? Only 2. You like whey protein? Do you give people whey protein? Please tell us your experience with whey protein.
I don't know what are pure, ISO?
So whey protein is actually leucine, which is an amino acid. I mean, it's got the non-lactose, it's got protein in the whey, the water that comes out when you take off the rest of the protein. And it helps to incorporate amino acids. I think it's leucine which is there. Is that what you're saying? Incorporate amino acids into the muscle much faster than anything else. So whey protein is what is taken by, it's a huge business. It's taken by all these athletes, and because it's not a drug, so it's allowed by the anti-doping test. They put on muscle and it's very effective. But there's a slight caution. There's few small studies in the elderly, and it's not bad. But they warn that the time is not yet ripe to give a prescription for whey protein for the elderly because it is not a pharmaceutical agent, it's a nutraceutical agent, which means that it is not as rigorously regulated and purified. It may contain some toxins. And so the road is not clear. But just keep this at the back of your mind.
No, not
nephrotoxin. Maybe, but it's not directly that. It's got some kind of toxins, like even things, rare elements like titanium and all that.
Lead, like any contaminant.
Yeah, which may not be. Whereas for drugs, we are very, meticulous about it.
What is your recommendation on gram per kg body weight of protein?
Well, they say 1 gram per kilogram, but I doubt that anybody here takes 70 grams protein. Because I don't think I take 70 grams protein. I'm more than 70 kgs. So what happens is we forget to count that 7% of our cereals actually also have protein. We only look at the actual meat. Any one portion of meat is 20 grams flat protein, one serving. If you take a serving of a vegetarian protein like dal, it's 14 only. It's 10. It's almost half the quantity of a meat. But if you can take, and remember, vegetable protein doesn't contain all the amino acids in that dish. So that's why we don't call it second class protein, but we call the other one as a first class protein. But the point is you easily overcome that by taking different forms of vegetable protein. So what amino acids are lacking in one will be made up by another. So vegetarian diet is absolutely perfect for the human body, doesn't have to consume meat. However, one drawback, anyone knows? B12. B12. There's no B12 and there's no cholesterol in the plant kingdom. Sad. No B12 and no cholesterol. They don't have B12. Milk has got B12.
Slight.
It's an animal product, slight. But for vegans, fortunately in India we don't have this vegan class. Okay?
We have.
Those who are lactose intolerant Indians. I think Indians, we love our milk, we love our ghee and all those things. The ghee, all that. So there is some B12 in that. And that's usually sufficient. But elderly vegetarians are at great risk of B12 deficiency. All elderly are at great risk. Fermented yeast, that will have. Yeast will have. B vitamins a lot, but B12, I think, maybe you're right. But no. It's negligible. Oh, curd, because it's milk. Yes. But it's very small. And then as you age, the stomach lining becomes thin. The hydrochloric acid comes low. So it's unable to extract B12 in the food. But if you take a B12 supplement, there's no doubt. There's no problem. But you need acid to cut out separate that B12 from your food. So B12 supplementation I freely give to all my patients, but not what comes in a multivitamin. I don't give multivitamin to a person who's got good teeth and has got a good appetite. I say you must get your multivitamins from your diet because in addition to vitamins, you've got many other micronutrients which you don't get in a pill. Fruits is something which my patients hate. I do not know why. So I don't know about, yes. I don't think so.
He asked if B12 gets destroyed by
Uh,
boiling of milk. Probably
I don't know about that. I haven't heard of that.
no. Do sprouts contain B12?
It's
No.
not B12, but it's many other good things.
Protein
Many other
especially.
good things, proteins and many other antioxidants. And
We'll
Magnesium.
not detail nutrition for the moment. But we'll. What is the relationship of the gut microbiota to inflammatory processes of aging?
I don't know the answer.
Nobody
don't know.
probably knows the answer. Yeah.
But it's very important in disease. Yeah, gut microbiome is now a big thing. It's very important in so many different aspects. I don't know about aging as such, but certainly in GI disturbances and in general immunology, it's very important.
We discussed instability, we discussed falls, we discussed sarcopenia.
Falls and drugs.
Falls and drugs.
Drugs. Now this diuretics which I was expounding is one thing which can give rise to falls. And then we come across this huge thing called benzodiazepines. Can I ask? Of course, neurogenerative we are talking now of just drugs. Any peripheral neuropathy, neurogenerative, Parkinson's, all of them will give rise to falls. But in terms of drugs, I just want to know how many people there are who do not prescribe benzodiazepines.
Consciously do not prescribe sleep ke liye benzodiazepines. Okay.
Okay, that's very good to know.
Then you may ask them this follow-up question. What do you prescribe for sleep?
Yes, what do you do for sleep then?
Dr. Kumuda, what do you prescribe for sleep? Nothing, you let them be
No,
insomnic.
somebody is saying something. Sleep hygiene.
Melatonin.
Melatonin. Okay, is it useful? Melatonin? Melatonin is not useful in everybody. It's only useful in those who have sleep onset insomnia. And also, they're supposed to take it 1 hour before bedtime. It doesn't help many people. I also do prescribe. Do you get it freely?
Yes.
Yes, okay. It's not so freely available. We, of course, think of it as jet lag medicine. It's not 100%. So sleep hygiene. Can we allow her to tell us about sleep hygiene? Would you tell us?
Dr. Adwari,
Regular waking hours, she says. Always get up at 6 or 5, whatever.
you'll have to repeat what they say because they.
Sorry, no? No stimulating activities,
Like
no
telephones,
caffeine,
television.
no mobile phone. Tea, coffee, they all contain caffeine, stimulants. No alcohol. Hot shower before bath. As Indians, we don't take bath in the evening, frankly. We like to take a bath in the morning, okay? So, nobody so far has said exercise.
Okay.
Physical exercise and tire yourself out, but not late in the evening. It should be early on in the evening or morning. That exercise has to be there. No afternoon naps. That takes away. And then they say, if you're lying in bed and you can't sleep, you've counted 2 crore sheep already, get out of the bed. They say 30 minutes, get out of the bed and do some pleasurable activity, not Sudoku, not phone, not WhatsApp, music, something which... Has anyone tried that? I have tried it. Nothing works. For 2 years, I did a 5,000 jigsaw puzzle. I just got up and I put on all the lights and I put the pieces in. When I was exhausted, when my mind was exhausted, then I could sleep. That's not
The solution.
so, yes.
What
Yes,
is your...
You're absolutely right. But the thing that But what happens to people like me who don't want to read the Mahabharata, you know? Very good. Tryptophan, threonine containing things, or serotonin enhancing things like banana and green tea and all that. I tell you, somebody in their wrong mind came up with these things. You try doing it. But all I'm trying to say is, the time is ripe for you guys to come up with some things, and don't just say it, do some research. You know, I'm not a researcher, but I have great respect for researchers, and I feel the time is ripe when now every doctor must get together in groups and do little studies, and none other than
insomnia.
something, everything. Decide on a research product. Yes, somebody.
He says one prayer to the Lord. Yeah. He takes 2 minutes to sleep, go to sleep.
Sir, excuse me, are we allowed to ask you your age?
What's your age? He's
No.
63.
Okay. So you are young old. Okay. Please, I challenge you, when you're old, then you see what.
Okay, so before we cut this short by asking you, how much pharmacotherapy should we give, if at all we give pharmacotherapy for sleep? What pharmacotherapy?
Zero.
Zero.
Zero. I have never given. I can put my hand on my heart and somebody pleads with me and said, please give. I have taken, maybe we can ask, how many people have never taken? I have taken Valium those days once in my life. And it is fantastic. It's like you put off the light, you're out, and you get up next morning, there's no hangover. It is fantastic.
Okay, I'm going to have a debate with her. Okay, I prescribe sleeping medicines, sleep aids, including benzodiazepines. In fact, lorazepam is my go-to drug. In chronic insomnia, where CBT, cognitive behavioral therapy, is the approved form of therapy for chronic insomnia, we do know that CBT is not easily available, and it is a tedious process. I have had relatives go through CBT. And it is as useless as melatonin, let me tell you that. But the point is not that. The point is it's not available, CBT. And is insomnia a risk factor for anything? Like people say sleeping less than 5 hours is a risk factor. Do you think it's a risk factor?
Definitely.
Of what?
Mortality.
Increased mortality. And is benzodiazepines a risk factor for increased mortality?
Yes.
It is. So now
It causes not only dementia, it causes falls, it causes delirium, it does everything. So both ways you're stuck. So better to have normal mortality with low sleep rather than enhanced mortality.
Natural mortality instead of iatrogenic mortality. So that let the patient be miserable, but let him die.
Craggy in the morning, throwing tantrums because he didn't sleep. That's better.
Yeah.
Than have a zombie in the morning. But one thing about, I'm very surprised that Dr. Shah, whose knowledge of pharmacology is better than most pharmacologists, has the audacity to say that he gives benzodiazepines. Do you know the pharmacokinetics of benzodiazepines?
I would not give it in a 75, 85-year-old, but for a 50-year-old who has chronic insomnia, I would gladly prescribe it.
For how long?
It is a lifelong medication.
You can prescribe benzodiazepines.
For not
even
more than
I will
30
give
days.
benzodiazepines for 7 days. For a person who has had such a severe anxiety, daughter failed in the exam, somebody died, somebody had a divorce, certainly you have to. As an anti-anxiety, there are other medications, but that's the best. But beyond 7 days, in my department in medicine, nobody could prescribe a benzodiazepine for more than 7 days. That prescription would come to me, but it never came to me. Either they didn't give it to me or nobody actually prescribed it. Because the body fat increases in the elderly as compared to the body water, if you think of a two-compartment model. Benzodiazepines are highly soluble in fat. So they get deposited, the volume of distribution, it's all distributed in the fat compartment of your body and slowly released over the day. So you're drowsy in the day. Even if you're not drowsy, your reflexes are a little wonky. If you're driving a car, you'll have an accident. If you're just walking on the road, you'll have a fall. And then your mental processes, you'll get dementia. And nobody will know it till you get admitted in a hospital for a hernia operation or something. And they forget to give you your Ativan. You'll go into delirium next morning because of withdrawal. So, you know, benzodiazepine. And then Z drugs, the zolpidem and all those drugs, they say they're less addictive, but not maybe at lower doses demand, but I have never been impressed by them.
Magnesium as a sleeping aid.
I think you. So it's your, if I may be so rude as to ask you, on what numbers do you base this? How many people you have given? And was it a randomized control trial? Sorry, we don't accept, unless you do an RCT, we don't accept. So please do the study, community-based. You know what you need to do? If you're a researcher yourself, you know research methodology, you can do it, but why don't you invite a researcher? Talk about simple research method, research in a community setting. Very few people in the world are doing it, but it has to happen. It has to happen outside teaching hospitals. Research has to happen on the ground. So get hooked on to this, because it has to be high quality research. In the beginning, let it just be an observational study. Then you can give magnesium to one lot, no magnesium to another, match your groups, and you come out with this thing. No, you have a tool to test sleep, whatever. I think it can be easily done.
Yeah, we will. So what she's asking is, if a person is prone to anxiety and has to go into that MRI machine, would you give anything?
If it's very severe, that is just a
One dose, yeah.
And for outpatient procedure nowadays, they give midazolam, which is a benzodiazepine, very short acting. Cannot give, but we wouldn't give it for an MRI. I've never heard of somebody getting so much, but odd patient. Yeah. Oh, you.
Okay, we'll go. Yeah, last question here. He's asking daytime excessive sleepiness in old age. How do you kind of investigate? What do you look for?
First thing is obstructive sleep apnea. So it is more common than we think. It has very bizarre manifestations. But the most important one is daytime drowsiness. And if you have somebody who's constantly bashing up his car, please think of daytime drowsiness. They will deny that they slept. But, they sleep off at the wheel. How many people at the age of 80 here are driving? I don't know. But it's only going to increase. Because now we are a driving population. I would refuse to give up my car in the next 5 years. Never. So, if I have sleep apnea, which I have, I've got to make sure that I'm correcting my sleep apnea. Because that's how I detected I had sleep apnea.
Wow.
I
Bang.
dashed into the median at 3 in the afternoon, and my only fear was, did anybody see me? How can the shame of having dashed into the median, when nobody was pushing me or doing anything. So I immediately got my test done. I knew before that I'm having it. And they rang me up. I had just had a home screening test, not the full-blown. They rang me up and they've got you severe sleep apnea. I said, how dare you say that? I'm not so obese. So now I read up and found postmenopausal women, 20% have sleep apnea. because this part becomes so loose, it just obstructs. And daytime drowsiness. So I was wondering why my PG students, when they're giving this seminars anyway, PG seminars are boring. But even the exciting seminars, I was falling off the chair. It was very embarrassing. When I started my CPAP, I'm fine. So, daytime drowsiness, please look at that. Also look at poor sleep at night, insomnia per se. And then, of course, the use of benzodiazepines. Somewhere he's taking a benzodiazepine unknown to himself or to you. These are some of the things. And of course, heart failure, hypothyroidism, all these things are, heart failure can give rise to severe fatigue. And they don't have breathlessness. That's the part of the old age bizarre symptoms. There'll be no breathlessness. But they'll have insomnia because they can't lie flat. They don't know why they can't lie flat. And then such severe fatigue that they just... One good thing you were talking about insomnia is, I think we should look at yoga. Yoga, that lady has gone. So I find myself and with others, I don't want to just promote I'm talking too much about myself. If you relax physically every muscle in your body, it's much easier. Yes, madam.
She would suggest Vipassana meditation
I
for
think
sleep.
these are fantastic, unexplored things. We know about it, but we don't know its relationship to sleep.
Again, something in both yoga and Vipassana, we would need RCTs to convince
Yes.
ourselves also. That feedback is, what she's saying is that the breath, if she concentrates on her breath at the time of sleeping, that promotes sleep. Yeah.
I fully agree with that. But to prove to the world, see, you, by telling me, I believe it.
Anecdotal for
It's anecdotal. We must do the research. There's so much that we know as knowledge, but we can't prove it. But it's not enough to say I've done it. It's not, no, you have to prove it. So prove it.
Yeah, we'll go ahead. Yeah,
Yes. Good. So we'll await the research.
She spoke about a very interesting thing. Snehal, you want to say something? What she's saying is maintaining sleep hygiene, of course, and sleep diary with cognitive behavioral therapy probably. So yeah, this is an area where we probably have a lot to do.
But one more thing, since sleep is so central to much of our practice, we fail to realize there are certain drugs and certain comorbidities.
Which cause insomnia.
Yeah. So anybody with COPD, GERD actually, because some people don't have the pain, they just cough, and heart failure, and menopause by itself per se. Drugs such as beta blockers will deny you sleep, and steroids, and what else? Pain. So, before you label as a person as pure primary insomnia, I don't think that's a word, primary insomnia, please ask all these questions. And you may not be able to take off the drug, but if it's a beta blocker, some of the newer ones, like Nebivolol and all are much better in this, you can try.
She spoke about equivalent, wait a minute. She spoke about equivalent symptoms, sometimes that insomnia can represent something else, for example. So tell us about some geriatric symptoms which may be actually due to causes which we don't suspect. For example, you said cough may be heart failure related when patient does not have dyspnea, because the patient does not walk, so dyspnea and exertion is not noticed and only cough comes up. Any other symptoms that you can think of?
Which actually is the big elephant in the room we didn't talk about, insomnia. Think of depression.
Insomnia as a symptom of depression.
But having said that, most elderly insomniacs are not depressed. Your common garden guy patient who, he's not depressed, okay? I'm just saying. But in that group, there'll be a few who are depressed. Just like there are few who've got unidentified heart failure. There are few who actually got asthma or COPD. So if somebody comes with insomnia, which you have tried all the sleep hygiene or thing, try to get that constellation of symptoms which might suggest that he's depressed. And as we were talking, depression is something which is poorly recognized by general practitioners and all non-psychiatrists all over the world. In the West, in America, they overdiagnose. Everybody's depressed. They themselves will go and tell, I'm depressed. They go straight to a therapist. In fact, at one time they said, can we put Prozac in the tap water? Then all of us will be bouncing away. So from that extreme, we come to India. In my practice in CMC, I found the psychiatrists always told us, you guys just don't diagnose depression. And when you send us depression, they are suicidal. So you aren't doing anything. So we had many courses, so we were a little bit better in diagnosing depression. So insomnia. There are many other cues, but insomniac patient, you can ask them a few questions. Are you feeling tired? Yes, everybody's tired. But is it excessive tiredness without a cause? If they've got heart failure, yes, tired. If they've got something else, they're tired. But unexplained tiredness. Unexplained, the person says, I'm so tired, I can't even go and cook. I can't do cook. Okay, do you want to cook? Or you just don't want to? No, I don't want to cook. But somebody says, I love to make the biryani, I just don't have the energy. That's also a plus point. But if don't like to do it, and I don't have the energy to do it, that's a stronger thing. Oh, my bahu bhi kabhi saas thi, or saas bhi kabhi bahu thi. I don't like to see it anymore. Pleasurable activities are less pleasurable now. So then everything, my family is falling apart and it's all my fault. Guilt. A feeling of worthless. What did I do my whole life? I just stayed at home. Finished my job. There's a feeling of worthlessness. Okay. So then lack of appetite, which is not due to any other cause. Maybe constipation. These are all the vegetative symptoms of depression. So constipation, which is not due to anything else. So you come across a mixture of 8 to 9 things. And then you have to ask that one question, which I hate to ask. Do you want to? Suicidal intent. Do you want to kill yourself? All of us feel that if we ask somebody that, they'll go and kill themselves the next day. But I'm assured by all my psychiatry friends that every one of us has entertained the thought of killing ourselves. And by asking that question, you will not push anybody, but it feels a bit crude to ask that. So you ask in a nice way, do you sometimes feel as though, am I living, And they'll, as I was telling Tushar the other day, one of my patients had so many problems, I don't know what was wrong with him, and so I did the easy way out, was to do a whole lot of tests, When you don't know what to do, you do a whole lot of tests. As this person was going out of the gate, I said, something is wrong. I said, come back. Do you ever feel that life is not worth living? How did you know, doctor? Every time I go in the house, I want to climb this top and jump from there. But I'm a true Christian. I think it's a very bad thing. I sit down and pray every day. God, don't let me jump off. So you see, that never came out in the consultation because I didn't give the space to the person. I was giving only tests to do. So you have to have that in your mind that the highest suicidal person is adolescent and old age. Because when you're a young adult, you've got family, you've got to do this, you've got goals, you've got this thing, And if you're performing reasonably well, you've got a good sense of self-esteem, this, that, and that. But, and it's not feeling sad. All of us sometimes think that feeling sad is equal to depression. Sadness is only one tiny bit of depression. So all these things, if you have it, diagnose depression early, if treat it, but if it's major in the sense that a person has got suicidal intent, has planned it, has attempted it, don't try to treat that person. Please send them straight to a psychiatrist. So in insomnia, one of the things is that.
I think we'll break for tea.
And this early morning waking, 2 o'clock, that's more.
Is a symptom of depression.
Rather than sleep onset.
Sleep maintenance problem may be a symptom of depression. Easy crying as a symptom of depression. Would you say that? Easy crying? I cry while watching movies. Makes me suicidal. Yeah.
Yes, it could
can be of course
anxiety,
a symptom of
anxiety and depression. But then you must have other things. You must have at least 4 symptoms.
Okay, we are a large crowd, so please bear with the services, but tea is ready, and and we have 2 more topics to cover, which is immobility, impaired cognition, and a few diseases to cover. So please be back in 10 minutes.